is work that actually, a lot of it was done over that period, looking at blood pressure and cardiovascular risk, and thinking about what the epidemiology tells us, and then how that, I think, should guide the interpretation of the randomized trials, and most importantly, the implementation of the knowledge we gain from that about both treatment strategies and also with drugs, but also other strategies for lowering blood pressure. So here is the summary from the European Heart Journal 2018 of the European Society of Cardiology and the European Society of Hypertension Joint Task Force on blood pressure guidelines, subdividing blood pressure from optimal through to high normal to various grades of hypertension, and various cut points by systolic or diastolic blood pressure. And they then divide that into normotensive, that is a systolic below 140, diastolic below 90, or hypertension with levels above that. And when one looks at the associations between the risk, in this case of stroke, the same would be true of coronary artery disease, and blood pressure, plotted on kind of standard scale, then one can understand to some extent why it is there's that dichotomous approach to blood pressure. If one looks at this curve, which comes from the Prospective Studies Collaborative meta-analysis, now led by Sarah Lewington in the department, a publication here from Lancet 2002, what one sees is this curvilinear association where I think the interpretation is that it's pretty flat up to a systolic of about 140, but then the curve takes off. And at that point, increasing blood pressure appears to be strongly associated with increase in the risk of stroke or coronary artery disease. And so this cut point of 140 appears to be where the line takes off. I think probably as a consequence of the last year, there is almost nobody in the world who's not now familiar with the concept of log scales, perhaps other than those who write guidelines about blood pressure. But if you do plot this on a log scale, that curvilinear association becomes a straight line. So we see here the same data plotted with a doubling or log scale on the left. And the interpretation of that is that throughout the range studied, the same absolute difference in blood pressure is associated with the same proportional difference in risk throughout the range. So the idea that where that red arrow is, of a systolic of 140, there is some magical difference in the association really kind of disappears if one looks at the data in this different way. And I think that has quite profound implications for thinking about lowering blood pressure, whether through drugs or indeed through diet, because it suggests that lowering blood pressure wherever you are on this blood pressure scale should be associated with lowering of risk, and that the same absolute difference, as I said earlier, would be associated with the same proportional difference in risk. So fundamentally, I think it suggests that the kind of underlying philosophy of the guidelines are false, that the idea of normotensive or hypertensive is actually quite misleading. One can look at this in more detail for stroke, for coronary artery disease, and for other vascular causes. For each of these three causes, it's a log linear association, and the slope of that log linear association is steeper at younger ages. So you can see here that the relative risk is stronger at younger ages than at older ages. However, bear in mind that older people have higher absolute risk, so that in fact the same absolute difference in blood pressure is associated with a bigger absolute difference in risk in older people than younger people. And within any age group, again, because it's log linear, the same absolute difference in blood pressure is associated with the same proportional difference in risk. So the interpretation that the curves are flatter at older ages, and that it therefore may not be valuable to lower blood pressure at older ages, fails to take into account the fact that the people are at higher absolute risk and therefore will actually get a bigger absolute benefit from lowering their blood pressure by the same amount as is in a younger individual. So we move away from the idea of treating high blood pressure to the idea, as has now been much more widely adopted with, say, cholesterol lowering, of treating high risk and lowering that risk irrespective of the blood pressure or, to take the other analogy, cholesterol level. I think it's really important to also think about the blood pressure in the context of the world as a whole. So if we think about a continuous relationship down below what is considered to be that cut point, then we actually will estimate the importance of blood pressure as much greater than would be the case if we only think about the association of blood pressure above the cut points of 140/90. The way in which people think about blood pressure at the moment, that is, what's the risk associated with so-called hypertension, is a little bit like saying, what's the risk of smoking if 10 cigarettes a day is normal? So once we start to see this as a continuous relationship throughout the range, we realize that there's a risk of underestimating very importantly the value of lowering blood pressure to more optimal levels. And so in a paper in Lancet 2018, Laws estimated that if you took a systolic greater than 115, then half of all stroke and coronary disease is due to non-optimal blood pressure. That half is among those without so-called hypertension. Half is among middle-aged people, but half is among older people. And importantly, which I think we'll come on to in the later talks, 85% of the burden is suffered in populations from lower middle-income countries. So we need to have strategies that are relevant to those populations and not just to the wealthy. Malcolm Law and Nick Wald and others published a very nice paper in the British Medical Journal in 2009, looking now not at the observational epidemiology, but the randomized controlled trials, and showed in this meta-analysis exactly what you would expect from the observational epidemiology, and that is that you get a similar proportional reduction in risk by lowering blood pressure with treatment, irrespective of the initial blood pressure. So the same absolute reduction in blood pressure is not just associated with the same proportional lower risk, but is actually associated with the same reduction in risk. So now we're looking at intervention, irrespective of the starting level for both coronary artery disease and strokes. The SPRINT trial in the New England Journal kind of reinforces that point. So standard treatment to get patients below 140 compared with more intensive treatment to get systolic blood pressure down to 120 was associated with a significant reduction in the risk of cardiovascular events. And that targeting less than 120 rather than less than 140 not only reduced risk, but it did so safely without having adverse consequences. Nick Wald and others also looked at what kind of treatment regimens would one want to use in order to optimize the benefit of lowering blood pressure. In summary, what they saw was that for the same achieved reduction in blood pressure, there's little efficacy difference between commonly used regimens. This is very nicely demonstrated by the work that's coordinated out of the George Institute in Sydney from the Blood Pressure Lowering Treatment Trials Collaboration. This is a publication from Lancet in 2003, but they have done further updates which reinforce this, which indicate that the proportional reduction in risk here of coronary artery disease is associated with the absolute reduction in blood pressure, irrespective of the regimen. So the calcium antagonist producing a bigger absolute reduction in blood pressure produce a bigger proportional reduction in risk. The ACE inhibitors, intermediate. The ARBs, lower. More intensive versus less intensive. The reduction in risk is proportional to the absolute reduction in blood pressure between more versus less. And when one compares different agents, as the pharmaceutical companies are want to do, to try to make claims that their agent is better than the other agent, actually, if you get no difference in blood pressure between the different agents, then you get no difference in risk. And this shows exactly the same thing for stroke, which is perhaps a bit more sensitive because the reductions in stroke associated with lowering blood pressure tend to be bigger. But we see the same pattern. It doesn't matter which agent you use. What matters is lowering the blood pressure. But Wald et al. Also pointed out that monotherapy typically reduces blood pressure only modestly, that increasing the dose of a particular agent has diminishing marginal returns, but it does increase the side effects. And that by contrast, the addition of another agent, a low dose of another agent, produces almost exactly additive blood pressure lowering effects. And so they concluded that the strategy, once you've decided that lowering blood pressure makes sense, the strategy should be to use a combination of low or moderate doses of several agents in order to get the largest blood pressure reduction and therefore the largest cardiovascular benefits, while minimizing the risk of side effects associated with a particular agent. Bearing in mind, of course, if one lowers blood pressure too much, then people do start to get symptomatic problems. And this just summarizes their data. The white bars showing the effect of adding another drug. The black bars showing the effect of doubling the dose of the same drug. One can see on the y-axis that the 1.0 is indicating that you essentially get a pretty much additive effect, whereas doubling the dose is producing only about a 20% increase, irrespective of the agent used. Finally, though, why are we interested in the management of hypertension? Or if you like, why are we interested in lowering blood pressure? Well, of course, the reason why we want to lower blood pressure is because we want to lower risk. But if that's the case, why is it that when patients are considered to be at high enough risk of heart disease, heart attacks, or strokes, to give them an antihypertensive therapy, doctors don't actually consider using other ways of lowering their risk? So if we look at some recent trials, such as the SPRINT trial, or relatively recent surveys of treatment across Europe, the EUROASPIRE study, the proportions of patients who were considered to be at high enough risk for primary prevention by lowering blood pressure, who were also getting their risk lowered with lipid-lowering therapy, was less than half. 44% in SPRINT, only 28% in EUROASPIRE, despite the clear evidence from randomized trials of lowering LDL cholesterol with statins of benefits on both coronary events and strokes. And if we go back to those 2018 ESC, ESH guidelines on blood pressure control, only one of the 98 pages in those guidelines relate to the management of concomitant cardiovascular disease risk. This undue focus on the risk factor rather than on the reason why one should be interested in the risk factor, that is to lower risk, is really quite bizarre. As I say, we have very good evidence that in people who have high blood pressure, people who are being treated with hypertension, then that lowering their LDL cholesterol with a statin lowers their risk further. So there really, I think, is no excuse, having decided that someone's at high enough risk to lower blood pressure, not to consider other interventions. I'm looking at lowering cholesterol here, but one can think of other things that should be done at the same time. So in conclusion, I think this is where it leads into what we might want to have as guidelines for the world, is keep it simple. By contrast, if you look at those 97 of the 98 pages that focus on blood pressure and ask yourself, why is there so much written about something so relatively simple? The reason is that there's an enormous lot of work and description about complex titrations of which drug to start with, how to decide whether to go from the first drug to the second drug to the third drug, when all of the evidence suggests that having decided that lowering blood pressure is a good idea in an individual, it would make more sense to start with simple combination therapy rather than complex titrations, and that would be a much simpler message to be getting across in many populations around the world. Unfortunately, that's not what happens. So in a visit I had to China, WHO was spending enormous amounts of effort trying to get the Chinese to follow the international guidelines with all of these complex titrations. And I think that that is a recipe for ensuring that patients who do need blood pressure lowering treatment don't get an effective regimen and are unlikely to be maintained at an optimal blood pressure. This concept of starting with a single agent and then titrating up, where we know that monotherapy produces only modest blood pressure reductions, and that just increasing the dose of those drugs, as is again recommended in the guidelines, really has diminishing returns in terms of further reductions in blood pressure or risk, but does increase side effects. And that by contrast, as I say, the combination of a few low dose agents would be much more effective. And that finally, having decided that it's a good idea to lower blood pressure, think about other ways to lower the risk of those individuals, statins, and obviously smoking, but there may be other things that one could do. And of course, the focus here of my talk has been on using blood pressure lowering treatments. But I think what the epidemiology and the trials of treatments demonstrate is the potential for benefit for population strategies for lowering blood pressure through diet and body weight control. Thank you very much.
Dr. Collins, thank you very much. Great presentation. We will have a discussion on that after the next talk, which is, I invite her most heartily, Nio Tapila. She is a senior research fellow in the Translational Epidemiology Unit in the Department of Public Population Health in Oxford. And she will speak about prevalence and determinants of hypertension control among almost 100,000 treated adults in the UK Biobank. Dear Dr. Tapila, please go ahead.
Thank you very much. Good afternoon and good morning. I want to confirm that everybody can see my slides.
I can.
Wonderful. It's a pleasure to be here amongst such a distinguished panel and audience. And we've just heard from Professor Collins about the effect of blood pressure on cardiovascular disease risk and outcomes, and some lessons related to treatment strategies that can be gleaned from those seminal studies he outlined. I'm going to be speaking about the status of hypertension control in the UK, and also associations that are factors that are associated with better hypertension control in the UK. I'll be reporting specifically on findings that we published recently in a paper where we use UK Biobank data and analyzed up to nearly 100,000 treated middle-aged adults in the UK. So as has already been highlighted, hypertension is a leading modifiable risk factor for cardiovascular diseases. It affects 1.3 billion people worldwide currently, and as has been mentioned, accounts for about half of strokes and ischemic heart disease. Despite studies such as SPRINT demonstrating the benefit of lowering blood pressure, as has been mentioned, and also despite the availability of effective, affordable medications, some of which have been around since the 1950s, a very high proportion of people with hypertension or with raised blood pressure have suboptimal levels of blood pressure. Studies have described lower levels of hypertension control among older aged adults, and they've also suggested that factors associated with lack of control may differ between different age groups. So it's in this context that we seek to understand or to determine the prevalence of hypertension control among treated middle-aged adults in the UK, and secondly, also to examine factors associated with hypertension control in this population. I'll point out that I'll touch on findings relevant to aim 1, but really focus on findings relevant to aim 2, which is associations. So in terms of methods, I've mentioned that we used data from UK Biobank, which I believe many, if not all, here are aware of. So suffice it to say that UK Biobank is a large population-based cohort study that enrolled 500,000 participants aged 40 to 69 years of age. And this was between the years 2006 and 2010. For this analysis, we used the data from the cross-sectional baseline survey of the UK Biobank, and specifically information from questionnaires, physical measurements, as well as some biochemical analyses of blood specimen. We seek to analyze treated hypertensive middle-aged adults, so we specifically define this as those who self-reported prior diagnosis of a hypertension diagnosis and also were on blood pressure lowering medications. In addition to self-report, we did a certain involved interview by a nurse, as well as review of a medication list that over 80% of those in our sample brought in from home. We excluded participants who were pregnant or had serious comorbidities, for example, stage 5 renal failure or recently diagnosed cancer. And the reason for this was that these patients might have different treatment goals in general and specific to hypertension from the typical hypertensive patient. Our primary outcome was hypertension control, which we defined as systolic blood pressure less than 140 and diastolic less than 90. So in keeping with the traditional dichotomous threshold that Rory has mentioned. And the measurement of blood pressure in UKB baseline survey involved 2 measurements in a single visit. This threshold was consistent with, this treatment target threshold is consistent with the NICE 2006 guidelines, which were operational at the time of enrollment. In terms of analysis, we conducted descriptive analyses as well as multidisciplinary logistic regression, adjusting for a variety of socio-demographic as well as clinical characteristics. So in total, we had 99,000 and slightly more than 99,000 participants in our analytic sample. Slightly more than half were male, and they tended to be a little bit on the older side of the 40 to 69 age range. The vast majority were white, self-reported white. In terms of lifestyle behavior, about half of them had a history of smoking, either current or previously, and 82% were obese or overweight, and about a fifth had a history of cardiovascular disease. In terms of the distribution of medications that participants were on, there was a distribution of variety, and about half of them were on only 1 medication, perhaps reflecting a titration approach to medication or to treatment, which was the paradigm at the time of enrollment in UKB. So what did we find? So in terms of prevalence, we found prevalence of hypertension control of 38% in this sample. That means that out of those who are diagnosed with hypertension are on medications and presumably in care, 3 in 5 did not achieve the threshold of 140/90 for target blood pressure. And our findings are somewhat lower than estimates by Health Survey England from around the same time. However, they're consistent with many studies that are published around the same time, including Pure Study, including a systematic review of over 90 countries that estimated high-income country prevalence of about 40%. More recent, so our data is from up to 2010, but more recent analysis was published in the Lancet, where it included analysis of population-based nationally representative surveys from 12 high-income countries, including the UK. And that analysis found that in the UK, 37% of adults aged 40 to 79 had hypertension control, so comparable with what we found, and also suggesting that the gap is consistent and remains even today. In terms of associations, we looked at sociodemographic associations and found similar to what has been reported in other studies. So we found that older age and being male was associated with lower control. And I just want to point out that our outcome here is hypertension control, which corresponds to a lower blood pressure. And so that might be a little counterintuitive for people who are used to looking at blood pressure specifically with these forest plots. We also found that compared to white people who were in the white ethnic group, Black people had lower odds of hypertension control, and this was after controlling for a variety of socioeconomic factors, including education, household income, and Townsend deprivation score. We found that alcohol or higher use of alcohol, as well as higher BMI, were associated with lower odds of hypertension control. This again is consistent with other studies and also our understanding of underlying mechanisms. Paradoxically, smoking, and specifically current smoking, was associated with higher odds of hypertension control. And one explanation for this is that providers were, they were treating patients who were smokers in a risk stratified manner. By that, I mean that they might have been trying harder to reduce the risk, cardiovascular disease risk of patients, and to treat blood pressure of patients who were smokers, recognizing that smoking is in addition to hypertension, so more cardiovascular disease risk. This explanation that is supported by some exploratory analyses that we did do. For example, we found that individuals who were smokers tended to have a higher number of antihypertensive medications compared to never smokers. And similarly, the number of medications tended to be higher for those with multiple cardiovascular disease risk factors compared to those with fewer. Interestingly, the factors that was most strongly associated with hypertension control was number of comorbidities, and we had a ratio of 2 compared to no comorbidities. We additionally looked at individual comorbidities and found that those conditions that were associated with cardiovascular disease risk, so for example, diabetes, tended to have higher odds of hypertension control. And so one explanation for this is similar to what I've just mentioned with smoking, which is that perhaps providers were seeing their patients and treating their patients in a cardiovascular disease risk stratified manner and looking at them more holistically in terms of cardiovascular disease risk rather than hypertension alone. Another explanation, of course, is healthcare utilization, and that's been described in many studies. So people with multiple comorbidities or multiple chronic conditions will tend to come to clinics and interact with providers more frequently. And that means that they might be more exposed to opportunistic blood pressure checks or counseling regarding health promotion, and as a result, control their blood pressure better. This latter explanation of healthcare utilization would explain seeing large number of comorbidities being associated with higher odds of blood pressure control, even for comorbidities that are not linked to cardiovascular disease, which is what we did see in our analysis. We've done some related work in resource-limited settings, including looking at the prevalence of hypertension control in Botswana and associated factors. We used a nationally representative population-based survey, cross-sectional survey conducted in 2014. where we found that the prevalence in the total adult population was 37%, and among adults aged 40 to 69 years of age, this was 32%. We've done follow-on work where we really wanted to understand, in addition to the associations that were found, factors associated with hypertension control, which are similar to UKB analysis. We wanted to look at what might be the underlying mechanisms for these associations, particularly associations with lower hypertension control. So that includes qualitative studies that have been conducted to look at what the patient experience is of hypertension care and challenges to having more than one chronic condition to manage. This work is being done as part of an MRC-funded feasibility trial, which we hope will inform development of a multi-component healthcare delivery intervention. And we're also doing some related work with multimorbidity as part of an MSc student project. So to summarize, our study is not without its limitations, including relying on self-reported measures, as well as potential healthy volunteer selection bias. However, it's contributed to the field and is one of the largest population-based analyses of hypertension control in middle-aged adults in the high-income country setting. We reported on suboptimal proportions of hypertension control in middle-aged adults in the UK and identified associated factors. And these together might contribute to further research and hopefully evidence-based strategies to help improve care and improve control of hypertension in high-income countries, but also very much needed in low and middle-income countries as well. Finally, I'd like to just say thank you to everybody who's made this work possible, in particular, David Hunter and Jennifer Collister and the rest of the Translational Epidemiology Unit and colleagues in Botswana for their continued support and collaboration. Thank you, and I look forward to the discussion.
Neo, thank you very, very much. Perhaps you can unshare. So, Neo, I want to add congratulations with this presentation and with your work. You have the best of two worlds. You have an MD from Harvard and an MPH from Oxford. It's absolutely great. And then you worked in the Botswana AIDS Institute. So not even two, three worlds, actually. Congratulations with that. Now, we have a bit of time for discussion. Whom may I invite for a question? And I propose you try to unmute yourself or speak up or raise your hand physically or electronically. I cannot very well much see you, but if you speak, if you have a question, please speak up. Just to Frank Hu. Frank Hu is very welcome here, Chair of Nutrition at the Harvard School of Public Health. Frank, please go ahead. Frank, I think you're still muted. Hannah, do we know a way to unmute?
So Bert, perhaps I could jump in with a question while Frank comes back?
Please, yeah, we hear Frank a little bit, but perhaps you have to adjust your microphone. David, please go ahead. David Hunter, Dr. David Hunter.
A question for Rory. So there is this, I don't know if it's dogma, but just this idea that blood pressure control is less important at older age. And one of the folk tales, at least, is that if you lower my blood pressure too aggressively at older age, you might knock me off cognitively. So would you like to address that? Because I think you were making the point that it's, the absolute differences are even larger at older age, and we shouldn't be so sanguine or permissive at older age.
Yeah, so the randomized trials that have been done in older people do show that lowering blood pressure lowers risk. They do not show any adverse effect on cognitive function. And so I think one of the differences of blood pressure from the analogy with blood lipids is we still haven't found a threshold below which lowering LDL cholesterol is not associated with lower risk and is associated with some increase in, say, symptomatic or other adverse effects. Whereas we do know if you lower blood pressure too much, then people start falling over. I think though that is, if you like, the threshold we're aware of, but there isn't any adverse, any evidence of adverse consequences, and indeed a number of the trials of blood pressure lowering therapy in older people were anticipating lowering blood pressure would actually improve cognitive function, although they haven't demonstrated that. So I think it's the absolute reduction in the risk of cardiovascular events, and in particular strokes, that needs to be taken much more seriously, because, I mean, quite clearly, if you want to have an adverse effect on cognitive function, then a stroke is not a great way of going. So I think this dogma largely came around from two things. One, the much flatter curves in the observational epidemiology at higher ages, and that in individual studies, it sometimes looked flat or even inverse. But when one combined the data on large enough numbers of individuals, then actually that appears to have been just the play of chance in individual studies, and you do get these very clear log linear associations, less steep in relative terms, more steep in absolute terms.
Thank you very much. Frank Hu, Frank, please.
Now can you hear me?
Yes, I can.
Rory, I have a question regarding the population attributable risk of almost 50% for CVD among people who are in the normal blood pressure range. That seems pretty high. So I was wondering how that PR was calculated and what's the reference group that was used to derive the 50% number.
I was actually going to suggest it might be a bit low, because it just does depend on what you consider normal. So they were essentially looking at less than 115, but I mean, actually the epidemiological associations suggest that blood pressure levels lower than that are associated with lower risk. So I think I mean, it's not the case that means that blood pressure is the only cause of 50%. In the same way that, you know, one can, I think, attribute 95% of coronary artery disease to blood cholesterol. If you, say, compare the rural Chinese of 30 years ago with Westerners, but that at least half, if probably more, of the risk would be avoided if everybody's blood pressure was below that level. Now, that's not going to be achieved by treatment. I think treatment is for people who are at high risk. But I think the next session on diet, and there are others in our department who are certainly looking at the impact of obesity and diet beyond salt, I think would argue that we could be producing much bigger reductions in the risk of cardiovascular disease by getting the population blood pressure levels down to humanly normal rather than levels of blood pressure that are considered normal by hypertension doctors.
Thank you very much. Can I take the liberty to ask, Neil, can I ask you a question? I remember quite some years ago that the summary of American hypertension control, it was presented in the case that I heard it by Jerry Stamler, was 50-50-50. Of those with hypertension, 50% is known. Of those who are known, 50% are treated. Of those who are treated, 50% is under control. How does that compare to your findings?
Thanks for that question. So our findings, the findings that I presented specifically looked at those the last number in that 50-50-50. So we were looking at of the people who are treated, what proportion are controlled. So that number was 38%, so lower than that last 50%. And so certainly low, and also lower compared to other high-income countries, as I've mentioned. For example, Germany, that number is 60% as of 2016. So I think that even by that benchmark, if you will, which is somewhat outdated, but by that benchmark, the results were suboptimal. I think there's a lot of advocacy to be able to actually have more aggressive targets than the 50-50-50, closer to 60 or 70%. Again, looking at countries that have done better with hypertension control than other countries.
Thank you very, very much. Very clear. Now we go to our next speaker, but before that, I would like to suggest, and I was thinking of that when Rory talked about normotensive, hypertensive. I was thought of Sir George Pickering. Everybody in Oxford, I presume, knows George Pickering, but perhaps not at Harvard. So that's why I wanted to present to you, have a look at the Platt-Pickering discussion. It was a very important epidemiological and otherwise discussion. What is it, Rory? 60, 70 years ago, perhaps even longer. And it still applies, it seems. Very nice. So George was, I think, for many years, was he the Regis professor at, yes, he was the Regis professor at Oxford. So let's now go to our next speaker, Dr. Nancy Cook. Nancy, wonderful to have you. You are in Eastern time, so it's in the morning for you. Dr. Cook is a professor of medicine at Harvard Medical School. She is also particularly at the Brigham and Women's Hospital. She's also a professor in the Department of Epidemiology of the Harvard Chan School of Public Health. And Dr. Cook will speak about sodium and cardiovascular disease, the state of the science. Dr. Cook.
Thank you very much. Let's see, can you see my slides?
Yes, I can.
Okay, terrific. So I'm going to talk about sodium and cardiovascular disease and go through a couple of examples and various studies that have been done on this. First of all, by way of background and outline, many societies have set dietary recommendations for sodium, but the average levels of intake actually greatly exceed these. The effects of sodium and blood pressure have been very well studied, and in general, they tend to be pretty well accepted, but the size of the effect has been argued, and the impact of that has been argued. And there's still a lot of controversy about the effects of sodium intake on subsequent cardiovascular disease and mortality. So the dietary recommendations in the US, the new guidelines were to consume less than 2,300 milligrams of sodium a day. And for those with hypertension or prehypertension, it's less than 1,500. And other countries' guidelines are fairly similar. In the UK, they say 2,400. Canada's Food Guide says 1,500 to 2,300. But the WHO and AHA guidelines are lower. WHO says less than 2,000. AHA recommends less than 1,500 for everyone. The average intake in the US is much higher than that at about 3,400 milligrams per day. And this slide shows the recommendations in blue and the actual average levels in orange for men on the left and women on the right. And you can see that at all age groups, the intake actually exceeds the recommended amount by quite a bit, particularly in men. And that's true worldwide as well. The countries that are in yellow are above that 2,300 level, and those that are in the red or orange are up to almost 6,000. So there's a great excess of sodium consumption way above the guidelines that are recommended, except perhaps for some countries in Africa and a few countries in the Americas. So what are these guidelines based on? Why are they so low? Well, they're based on studies of blood pressure primarily, thinking that sodium leads to changes in blood pressure, which affects cardiovascular disease. However, there are also thought to be more direct effects of sodium on cardiovascular disease as well. So first, looking at the a meta-analysis of sodium trials. This was done for the national academies in preparation for the dietary recommended intakes for sodium and potassium a couple of years ago. And looking at trials of sodium reduction, whether through lifestyle interventions, through salt substitutes, or from salt supplements, there were significant reductions in blood pressure. In hypertensives, the effect was much larger, reductions of 4 millimeters of mercury on average across all these trials, whereas in non-hypertensives, the reduction was much lower, only 1.3 on average. And in general, a lot of trials would show a difference of a reduction of 1 or 2 millimeters of mercury. And that might seem fairly small in those who don't have hypertension, but if you could enact such a change on a population-wide level, then you could actually get sizable reductions in disease. This concept was illustrated by Jeffrey Rose, Jerry Stamler, etc. And this one is looking at a small change of a 2 millimeter decrease in diastolic blood pressure. And this would reduce coronary heart disease by about 6% and stroke by about 15%, even though the blood pressure reduction was quite low. The trial that had the most impact on the guidelines in the past, however, was the DASH sodium trial. This was a very well-conducted feeding study where people were given their food to eat. So the direct quantities of sodium was well known. So people were randomized to either a control diet or a DASH diet, high in fruits, vegetables, low-fat dairy. And then within each group, they were randomized to high, medium, or low sodium in a crossover design. So people experienced all three types of sodium levels. And they found that even within each diet, there was a large reduction in blood pressure with reducing sodium, particularly with the control diet, which was the usual Western diet, but also in the DASH diet, going from the highest to the lowest, there was a reduction of about 3 millimeters on average, and it was higher, about 6 or 7 in the control diet. So this is a dose response meta-analysis of various trials by the net difference in sodium excretion. The top is systolic blood pressure, the bottom is diastolic. And you can see that with both supplementation and with diet studies, there is a direct response of the sodium levels with the blood pressure levels. And it was higher for the diet studies, but the supplementation trials as well, which tended to be shorter term, also found that increase. And when this was done in hypertensives and non-hypertensives, the difference was again larger in the hypertensive people, especially for systolic blood pressure. Now, what about outcomes? So these observational data and trial data both show that sodium intake is related to blood pressure. Reducing sodium leads to a blood pressure reduction, but there aren't many trial data on the effects of sodium intake or excretion on morbidity or mortality. So I'm first of all going to discuss TOPE, which I was involved with, originally the statistician for the coordinating center. This trial, the trial periods, TOPE 1 and 2, were led by people like Larry Apple, Paul Welton, and Jeff Cutler at NHLBI. So there were two phases. When TOPE 1 in 1987 to 90, which looked at 7 different interventions. There were 744 in the sodium reduction versus its comparison group, and they looked at blood pressure change over a year and a half. TOPE 2 carried forward sodium and weight reductions in 2,382 over 3 or 4 years. So these were blood pressure trials that looked at, and these were included in blood pressure meta-analyses, and they did show differences in blood pressure. These were people starting out with high normal blood pressure at the beginning, diastolic blood pressures between 80 and 90, or 83 and 90 in TOPE 2. But what we did then was conduct a follow-up study starting in 2004. And we looked at post-trial follow-up for cardiovascular disease through questionnaires. We looked at medical records, and we also followed up overall mortality for 23 to 26 years through the National Death Index. So when we looked at the randomized effects on cardiovascular disease over 15 years, we see TOPE 1 on the right and TOPE 2 on the left. Both of them showed a reduction in cardiovascular disease incidence over the 15 years. If you looked at the combined hazard ratio was 0.75. So there was a 25% reduction in cardiovascular disease over these 15 years. Now, the intervention didn't continue over that time past the initial blood pressure trials. However, this was a lifestyle intervention. People were taught how to reduce their sodium. They were looking at food labels. They were taught how to cook with different seasonings, etc., and how to choose one brand of crackers over the other. The aim was to reduce sodium, not to change other dietary components. So this was a learned behavior. And when we asked people about their behavior later on during this follow-up, those in the intervention group seemed to keep some of those habits that they had learned during the trial period. And we also looked at total mortality over 26 years, and there was some reduction even in total mortality. The hazard ratio was 0.85. It wasn't quite significant. However, if this was true, then that's quite a sizable reduction in mortality. As part of the National Academy meta-analysis, we looked at several other randomized trials. There was a follow-up of TONE. There was a Taiwanese study in veterans' homes of salt substitution. There was a China salt substitute study. And overall, for cardiovascular disease incidence, the relative risk was 0.72. And for total mortality, it was 0.89. So these other trials are consistent with TOPE in showing a later reduction in disease and mortality. So what about observational studies of sodium? It's very hard to capture usual sodium intake. Many studies use single-day diet recall, but most sodium is consumed in processed foods, which is very difficult to measure. The results of these studies tend to be inconsistent. Some of them included cardiovascular disease or hypertension. So there could be confounding by indication, reverse causation, and some didn't control for prior disease. I'm just going to go through a few of these that have been, a few of these ways of measuring sodium that are used in these trials. One was the 24-hour diet recall. First of all, there's possibly biased recall, so people may not report all the sodium or the chips or whatever they ate the previous day. It also varies from day to day. Food frequency questionnaires have a difficult time capturing sodium because so much of it's from processed foods. So even if it's crackers, it might vary from brand to brand. So something like that, where sodium is not, the majority of what we consume is not naturally occurring, but it's added in food processing or added at the table. And those things are very difficult to capture from food frequency. A lot of studies also use a morning or a spot urine sample. First of all, there's diurnal variation in that. There's day-to-day variation, and the absolute levels are off, and they need to be calibrated using equations. The gold standard is a 24-hour excretion, but of course this is difficult to obtain, especially in a very large study. People may not be willing to do this, but some studies do this. However, this also varies from day to day because it is a single day. At least it's a more accurate capture of what the person has eaten in the last period of time. So here are a couple of the studies that have reported on observational associations of sodium and cardiovascular disease. This one is looking at cardiovascular mortality. So this was done in 2 cohorts and published in JAMA in 2011, and they used a 24-hour urine sample. However, questions were raised afterwards about the collection completeness, possible confounding, possible reverse causation due to hypertension, and also control for blood pressure and hypertension medications. What they had found was that those in the lowest tertile of this excretion had the highest rates of cardiovascular mortality. The hazard ratio was 1.56 compared to a floating average. For incident cardiovascular disease, it was 1.13, so not nearly as large. However, this got quite a lot of attention. Many of the people were on hypertension medications, though. By controlling for that and for blood pressure, it adjusts for some effects that could be in the causal pathway. There are other studies, though, that showed a similar result. This was a study published again in JAMA in 2011 that looked at 2 trials of cardiovascular medication. So people on these trials, they collected a single spot urine. They had to adjust this to mimic a 24-hour excretion using a Kawasaki equation. So there are several concerns about it, though. One was the use of the single spot urine. Also, all of the participants had either cardiovascular disease or diabetes. So there's possible reverse causation. Most people who have these conditions are recommended to reduce their sodium intake, even though they're still at high risk. Those at higher risk might, lower their sodium, but still be at high risk due to other causes. Many are also on various medications, including diuretics, which may interact with the sodium reduction in their foods. Finally, I'll talk about the PURE study that had over 100,000 people in 17 countries. The exposure was a single morning void. Again, they used the Kawasaki formula to estimate a 24-hour excretion. And they found a J-shaped curve, which so increased risk at the lower end of the sodium, which had been found in by O'Donnell et al. As well. There are several concerns that were raised about this. Most importantly, this is a very heterogeneous population. There are 17 countries that had various levels of nutritional factors, socioeconomic status, access to healthcare reporting, malnutrition, many different differences in socioeconomic status. And it didn't appear that control was adequate for all of these different factors. There could be a lot of residual confounding. And in addition, the sodium exposure tended to be fairly weak. So a large study size, this study is remarkable in that it's huge, but a large study size doesn't always guarantee accuracy. So going back to TOPE, we also did an observational analyses, and those not in the sodium intervention. We felt that those in the intervention would have a short-term change in their sodium. What we're trying to get at was to capture their usual intake over a long period of time. So in TOPE 1, we had 5 to 7 measures of 24-hour excretions over a year and a half. And in TOPE 2, we had 3 to 5 measures spaced over 3 or 4 years. So what we did was average all of these sodium excretions to get an exposure period during the blood pressure trial. And then we looked at the post-trial follow-up for cardiovascular disease, again over 10 to 15 years, and for mortality over 23 to 26 years. So we had a very good measure of exposure, and then we had follow-up after that. And we found that using this average sodium, we found a direct and linear relationship with cardiovascular disease and with mortality. We found no evidence of a J-shaped curve, no evidence of a U. This was a spline curve, which is flexible, and there was no uptick at the lower end. And both of these were statistically significant. We also found that there was a even slightly stronger effect using the sodium-potassium ratio, which has been found by others as well. There was these were more highly significant and slightly stronger. So TOPE found a reduction in both cardiovascular disease and total mortality in their randomized data, and also in the observational data, using multiple high-quality 24-hour urines, which would reduce measurement error quite a bit. The TOPE cohort was healthy, no prior cardiovascular disease or diabetes. They were pre-hypertensive, so none of them were on medications at the beginning, so there was little potential for reverse causation and lowering sodium due to these disease conditions. We found a direct linear association of lower CVD with lower average sodium with no evidence of a J or a U shape. The other thing we looked at, though, was what about the measure of sodium? We wanted to see how much difference it made to use a single, say a spot type of urine versus a 24-hour urine specimen. So what we did, we used the concentrations to estimate what we would get using the Kawasaki formula. And we compared that to the 24-hour excretion using our data. So first of all, on the far right, you can see that the first predicted is that estimated from the Kawasaki equation. So on the left is the 24-hour excretion. On the right in that first figure is the estimated from the Kawasaki formula. And first of all, you can see that the levels are higher using the Kawasaki formula, and the variability is quite reduced. When you look at a Blant-Altman plot in the middle, you can see that there's a definite bias. The higher intakes are pulled in, the lower ones are brought up as well. So there's this curve generating a slope in the Blant-Altman plot. The same thing happens in the pure data. They published something very similar when they looked at blood pressure effects of sodium, and they found that same kind of relationship as we did. And then we looked at these different measures of sodium excretion and all-cause mortality. So in the upper right, A is what we found and what we had published based on the average measured. If we use the average estimated on the top right, this was using a Kawasaki formula using the average. So you actually do start to see an uptake at the bottom, but it's much less stable and less of a nice linear relationship. On the bottom on the left, we used the first measured, so that was a 24-hour excretion, and even there the curve was flattened. It doesn't have the precision of the multiple 24-hour specimens. And finally, on the bottom right, we used the first estimated, or that from a Kawasaki formula. And again, we see that the relationship at the bottom is altered, and we just see an effect at the very high levels. This is a recent meta-analysis looking at various observational studies, comparing the highest versus the lowest categories, however they were defined in each individual study. And this found a hazard ratio of 1.19 comparing these two categories for cardiovascular disease. In addition, they looked at the dose response. They first measured it as a linear association and found an increase, and they also looked at a nonlinear relationship. And in here again, they found no J-shaped curve, but an increasing risk over levels of sodium intake. I just want to mention another paper that was published last year in the European Heart Journal. This was an ecologic analysis of sodium intake and healthy life expectancy. So in the blue dots, it's looking at sodium intake. This healthy life expectancy, which seems to suggest that healthy life expectancy increases with increasing sodium. On the other hand, the all-cause mortality in red is decreasing with increasing sodium. However, this is an ecologic analysis, and so there is a lot of potential biases here. If you look at their plot of the various countries, you note that Africa has very low sodium intake, which is at the bottom in blue, in the top in red, but they also have low healthy life expectancy, whereas the the US, the UK, and most of Europe has higher sodium intake, but they also have higher life expectancy. But you can't directly correlate the two because there are so many other differences between them. To their credit, they did an analysis looking at high-income countries, but the same biases still occur, even if they may not be as extreme. So, and there are also several ongoing trials in people at high risk. There's the sodium heart failure, which is looking at 1,000 patients with heart failure, looking at mortality, CV hospitalization, ER visits. This one is ending in December of this year. There's a STIC trial, the sodium intake in chronic kidney disease. This is 105 kidney patients looking at change in creatinine clearance. And this ended in August, so we expect to see some results from them fairly soon. There's a China salt substitute and stroke study, which is very large, almost 21,000 participants in China. And this was a community intervention where they were giving them salt substitutes and to replace the sodium. This ended in September, so again, we hope to see results from this in the coming year. They did release some preliminary results looking at blood pressure changes, and at the top you can see that over time they did achieve some differences in systolic blood pressure over time. So again, this was an estimate published a couple of years ago in the New England Journal looking at the cardiovascular mortality that could be attributed to sodium consumption of more than 2 grams per day. And you can see that this is per million population. A lot of unnecessary cardiovascular deaths could be avoided if sodium could be reduced, particularly in the high consuming countries, and particularly in Asia, but across the world. So in conclusion, there's a large effect of sodium on blood pressure, especially in those with overt hypertension. It's smaller, but still a positive effect in normotensives as well. The strongest evidence supports a direct effect on cardiovascular disease. Those with hypertension or pre-hypertension are most likely to benefit from sodium reduction, but that's the majority of adults in the US, Canada, and the UK. Even in TOPE, which had pre-hypertension, found a large reduction in cardiovascular incidence. Whether it's practical to reduce sodium to 1,500 milligrams, though, remains a question. 2,300 might be more achievable in practice, but these do need the cooperation of the food industry. I think gradually they have been trying to reduce the amount of sodium in some of their foods, and if this is done gradually, then there's not so much of a difference in taste that people would notice and object to. If you do this all of a sudden, it'll taste bland, but if it's done in a gradual fashion, it's very achievable. So there does seem to be a benefit overall to sodium, and Yunma will present some more of these results with using some other studies as well. And thank you very much.
Dr. Cook, thank you very much for this comprehensive and very clear overview of the evidence. Thank you. And you have been involved in many of the studies yourself, indeed. Now we go immediately to our next speaker and final speaker before we have a little discussion, Dr. Yuan Ma. Yuan Ma is a research associate in the Department of Epidemiology of the Harvard Chan School. And Dr. Ma will speak about sodium intake and cardiovascular risk, a pooled analysis of 6 cohort studies with multiple 24-hour urine collections. Dr. Ma.
Thank you, Bert. Good morning and good afternoon. It's my great honor to present our recent work on sodium intake and cardiovascular risk in this HOPE symposium. As we have learned from the wonderful earlier talks of our distinguished speakers of today, there's compelling evidence showing that increased high sodium intake increases blood pressure, and elevated blood pressure is a key contributor to major cardiovascular events, both in a dose response manner. So isn't it reasonable to also expect a linear relationship between sodium intake and cardiovascular disease? As Professor Cook has nicely summarized in her talk, many methodological issues make this question a particularly challenging one to address. The current evidence mainly comes from prospective cohort studies, including the observational follow-up studies of randomized trials. Well, the body of evidence supports a linear relationship, emerging data from large-scale cohort studies, especially those where sodium was measured by spot urine, have reported a G-shaped or U-shaped association. To put our results into context later on, I'm showing here a U-shaped association of sodium intake with the risk of cardiovascular disease and death combined from a polling project where sodium intake was assessed by spot urine. What makes this finding controversial is not only the U-shape, but also the turning point of the U-shape. For example, the recommended sodium intake by many health organizations, such as the WHO, is no more than 2,000 milligrams per day, and the average sodium intakes of many populations lie somewhere between 3,000 and 4,000 milligrams per day on the left side of the curve. So if the association is interpreted as causal, it clearly challenges the current recommendations by many health organizations, and also it makes the public feel confused about whether to reduce sodium intake. And while we cannot completely rule out the biological plausibility of these findings, increasing studies have demonstrated the misleading role of many methodological limitations in these controversial findings, which Dr. Cook just fully discussed. So what can we do now to advance the evidence base before long-term randomized trial become available? One important step is to provide stronger evidence that overcomes these major methodological limitations. The first one is reverse causation, and to address this, it is important to conduct studies among healthy populations. And the other issue is the inaccurate sodium assessment, such as the use of spot urine and a single 24-hour urine. And to address this, it is important to assess sodium intake using the most reliable method of multiple 24-hour urine collections. However, it is challenging to collect 24-hour urine, let alone multiple ones. And this makes most studies with multiple 24-hour urine collection underpowered to address the important question on sodium intake and cardiovascular risk. So in the current study, we investigated the relationship between sodium intake and cardiovascular risk by combining the individual data from studies conducted in healthy populations with multiple 24-hour urine collections. And also, given the close interrelationship between sodium and potassium in blood pressure regulation, we also assessed potassium excretion as the secondary exposure. We included the studies that were conducted in healthy populations with at least 2 24-hour urine collected among more than 500 participants. And ultimately, 6 cohort studies from 3 research groups were eligible. And these studies include the health professionals follow-up study, the nurses health study, the nurses health study 2, which, as most of you know, are long-standing ongoing prospective cohort studies among health professionals and the registered nurses in the United States. And also the prevention of renal and vascular end-stage disease study, the PREVENT study, which is the prospective population-based cohort of nearly 9,000 adults in the Netherlands. And in the current analysis, we excluded those with chronic kidney disease at baseline, as well as the top 1 and top 2 follow-up studies, which are landmark studies in the field and were described in Dr. Cook's talk. In total, we included the individual data of more than 10,000 participants from these studies. And this slide shows the profile of the included studies. And over a median follow-up of 9 years, 566 cardiovascular events defined as a composite of coronary heart disease and stroke were identified. Our primary exposure was the average sodium excretion of all 24-hour urine samples for each person. And this box plot shows its distribution. The median sodium excretion was 3,300 milligram. And if we look at the 10th percentile of sodium excretion, it's closer to the upper limit of sodium intake recommended by American Heart Association for general adults, suggesting that around 90% of the participants consumed more sodium than recommended. And this slide shows our statistical method. In our primary analysis, we assess the association in individual studies separately using consistent methods, and then we polled the association estimates using random effects meta-analysis. And we also adjusted for the potential confounding factors listed on this slide. And due to time limit, we will not go into the further details of the methods, but I'm happy to discuss about this afterwards. Now we will go straight to the key findings. And this figure shows the association of urinary sodium excretion on the horizontal line with cardiovascular risk shown as the adjusted hazard ratio on the vertical line. As you can see, the risk of cardiovascular disease goes up gradually with higher quartile of sodium excretion, showing a clear dose-response association. And people having sodium intake in the top quartile had roughly 70% higher risk of developing cardiovascular disease compared to those in the lowest quartile. Our spline analysis using all the individual data also further supports a linear association over the range of sodium excretion within the study population. As you may recall, the turning point we saw earlier in the U-shaped curve, which was around 4,000 milligrams per day, clearly we didn't find any evidence of the U-shaped association. And also we did an interesting secondary analysis on sodium assessment. In our primary analysis, when multiple 24-hour urine sample were used to assess sodium excretion, every 1,000 milligram increase in sodium excretion was associated with 18% higher risk of cardiovascular disease. However, when one single 24-hour urine sample was used, the hazard ratio was attenuated to 1.09, and when the second 24-hour urine sodium excretion was used to correct for the random measurement error and also the within individual biological variation, the association estimate was even slightly higher than our primary analysis, but also with a wider confidence interval, suggesting the impact of measurement error on the association. And I'm happy to discuss this further later on if you are interested. Now back to our main results. We also observed that higher urinary potassium excretion was associated with lower risk of cardiovascular disease. And consistently, when the ratio of sodium and potassium was used, there was also a linear association with cardiovascular risk. We also performed several sensitivity analysis and secondary analysis and sensitivity analysis, and they all showed consistent results. Several limitations need to be noted. First, as a pooling analysis of individual level data, although we were able to reduce heterogeneity using consistent analytical methods, and also the association estimates in individual studies did not differ significantly, the heterogeneity in the design of the original study still exists. And secondly, we cannot, as an observational study, we still cannot rule out potential residual confounding, such as other unmeasured dietary factors. And also our study was based upon study populations mainly comprised of white participants. On the other hand, by combining the individual data from cohort studies with multiple 24-hour urine collection, our study is by far the largest one that have investigated cardiovascular risk in relation to sodium excretion measured by the most reliable methods. So to conclude, our study shows that higher sodium intake as higher sodium and lower potassium excretions measured by multiple 24-hour urine samples are associated with higher risk of cardiovascular disease in a dose-response manner. and these findings support the current recommendations to reduce sodium intake and increase potassium intake for the prevention of cardiovascular disease. In the end, I'd like to thank my mentors, Dr. Frank Hu, Dr. Albert Hoffman, and Dr. Nancy Cook, and all my collaborators for their guidance and great contributions to the project in many ways, and also thank American Heart Association for the fellowship funding support. And thank you very much for your attention, and I look forward to the discussion very much. Thank you.
Dr. Ma Yuan, thank you very, very much for an excellent presentation. Thank you. I take it, Nancy and Yuan, you would like perhaps to have questions. We have a few minutes. Whom can I give the floor for a question or a comment, please? You may wish to immediately speak up if you have a question. Robert Clark. Robert, please go ahead. Old friend. Robert, you're muted.
Congratulations on a lovely presentation, Juan. Could I ask you, what's the within-person variability in your 24-hour urine collection? So you measured it at serial times, because the key difference perhaps between the Kawasaki spot analysis used in the pure study and yours is the 24-hour versus the spot urine. So can you report on the self-correlation of the 24-hour measurement of urine at the 2 time points?
Sure. In our study, because it is the pooled analysis of different studies, and the interval of urine collection was slightly different in different studies, ranging from like 2 weeks apart to even 2 years apart. So the inter-class correlation coefficient ranges from 0.2 to 0.4 in different studies, depending on the intervals of urine collection.
Thanks.
Thank you. I have a question from Dr. Donna Spiegelman. Donna, please.
Yes, hi everybody. Thanks, that was a really interesting. I'm trying to turn my camera on so you guys can see me. Oh, I almost got it. Okay, there we go. Hi everybody. Yes, that was a really great and interesting talk. And I was wondering, a comment actually to the last speaker. I think that the measurement error correction that you did actually accommodates the different inter-class correlations or reliabilities from study to study. If I'm familiar with the methods that we've used for many of our other pooling projects, that would be the case. But I was wondering about the heterogeneity between studies and what was the R squared? Was it significant? Do you have a forest plot? And and then if there was significant heterogeneity, did you do any meta regression to kind of figure out what was going on?
Thank you, Dr. Spiderman, for your wonderful questions. So first, for your comments regarding the measurement correction, actually we used the methods you developed based on Dr. Rosner's approach to correct for measurement error, and we did that for each study individually. So we accounted for the interval difference. But the limitation of that analysis we did was that we only used the single 24-hour urine in the main analysis, and the secondary urine collection in the validation analysis, which means that if for the studies that have more than 2 24-hour urine collections, we didn't make full use of the data. So we are now trying to think whether there's a better ways to correct for measurement error in average sodium intake. And we are still in the progress of doing that. It still would be helpful to have your advice on that as well. We are working with Dr. Molin Wang on this. And also the second question regarding the heterogeneity of the findings, I just briefly mentioned that actually the results didn't differ significantly across the studies. The heterogeneity I mentioned was the design in the different studies, but statistically they showed similar. Well, statistically we didn't see any significant difference in the association estimates, but of course the magnitude is somewhat larger, somewhat small. So yeah.
Yeah, well, that's really important because even despite the differences in the designs and some of the exposure assessment methods, there's still a very strong, consistent result across all the studies. So that's a really important point.
Thanks, Donna. Yes.
Yeah.
Any perhaps final questions? We have 1 minute. You just speak up. I cannot see your hands. But if not, then it gives me a bit less than a minute to most sincerely, first of all, to congratulate our speakers. I think, can I say, as an observer and listener, you did a great job. Wonderful. Great overview. Major evidence presented. Can I also thank you, all those who were on the call? It was close to 150. This is for the Hope Symposia. Okay, it's only the second, I know, but it's a record. And so when it's organized by Oxford, there is a bigger attendance then, so we have to do better in Boston. And number 3, may I really, in this particular case, working with teams, may I most sincerely thank Hannah Freeman and Graham Bagley, behind the screens, and some helping us a bit in front of the screens as well. Thank you very, very much. With that, I thank you for your attention, for your attendance, and I hope to see you back, 1, in the weekly seminars, either of Oxford or of Harvard. We have them presented to you generally. And 2, at our next mini symposium. We don't know when, but it will be there. Thank you very much.